Hello, my name is Neil Kocher, and I'd like to thank the ICS for the opportunity to present our work entitled Predictive Factors of PNE Success in a Contemporary Series, a Single Institution Experience. I have no disclosures. Sacral neuromodulation is a well-established, minimally invasive technique for treating several refractory bladder and bowel conditions. PNE success rates, typically defined as conversion to a permanent implant, are reported between 40 to 50% using a single non-tined temporary lead. Compared to PNE, advanced evaluation with a permanent tined lead is approximately 77% successful, but requires a two-staged approach in the operating room under at least light sedation. With the availability of in-office fluoroscopy and refined technique, more contemporary data on PNE success rates are needed. The purpose of this study was to evaluate a recent series of PNE patients to determine overall success rates, as well as predictive factors toward PNE screening success and persistent functional response following permanent sacral neuromodulation implant. A retrospective review of all patients who underwent interstim peripheral nerve evaluation at a large tertiary academic center from 2015 to 2019 was performed. Patients with refractory urgency frequency syndrome, urgency incontinence, and/or fecal incontinence were included, whereas patients with chronic urinary retention were excluded. All unipolar leads using the Medtronic Basic Evaluation Lead Model 305901 were placed percutaneously in office under local anesthesia utilizing AP and lateral fluoroscopy by one of 4 FPMRS-trained urologists. Patients demonstrating an optimal response defined as at least 50% improvement in objective and subjective bladder diary information proceeded to single-stage sacral neuromodulation implant. Conversion rates to permanent implant after a successful PNE trial were reviewed. As most studies define PNE success as conversion to implantation, and recognizing that a proportion of successful PNE trials have suboptimal responses following permanent implant, we also evaluated for persistent patient-reported symptom improvement at latest available follow-up at least 1 month following single-stage implant as a marker for a durable positive screening test. 102 patients, including 87 females and 15 males, were included. Bilateral, unipolar leads were placed in 93% of patients, and appropriate needle position was confirmed using fluoroscopy as seen here. Of the 102 patients included, 78 patients, or 76.5%, were PNE responders, demonstrating at least 50% symptom improvement, and 24 patients, or roughly 24%, were PNE non-responders with less than 50% symptom improvement. On multivariate logistic regression, patient predictors of PNE success included younger age, mean age 64 versus 71 years, urgency incontinence, fecal incontinence, and absence of a neurologic diagnosis. Intraprocedural testing factors associated with PNE success included presence of both plantar toe flexion and anal bellows and perineal sensation. Of the 78 PNE responders that proceeded to permanent system implant, 68 patients, or 87%, maintained an optimal response at least 1 month follow-up, with a median postoperative follow-up time of 4 months. On multivariate logistic regression, the only statistically significant predictor of persistent implant success was absence of a neurologic diagnosis. This contemporary series revealed PNE screening rates equivalent to reports on staged implants. Patient predictors of PNE success included younger age, urgency incontinence, fecal incontinence, and absence of a neurologic diagnosis. PNE responders were also more likely to demonstrate both anal bellows and plantar toe flexion, as well as patient-reported perineal sensation as predictive of PNE success. The current study is limited by its retrospective design, smaller sample size, and shorter median duration follow-up of 4 months. In conclusion, this contemporary series of unselected patients undergoing PNE with fluoroscopy revealed screening rates equivalent to available reports on staged implant. PNE conversion rates to permanent implant may not be the ideal outcome as it may overestimate success, and evaluation for continued improvement at a minimum of 1 month post-permanent implant may be considered as a more reliable indicator of successful screening. Thank you again for this opportunity.